Jessica is one of those gift of other people to me. Anytime I've been on a Zoom with her, I think I come away just feeling so good about the world. She's just such a good human, and so polite, and so caring, and so freaking smart, and as intimidating as hell, but she's so humble about it. And I got to be a moderator for a session last fall with longevity, and got to moderate with Jessica. And just the way she handled all the patients online and the way she does things is the way it should be done. So we are very fortunate to have Jessica with us for this weekend and to give our keynote. Please give a big round of applause for Dr. Jessica Lin.
I'm so happy you're here. Thank you. Thank you for... I will take the pointer.
You might need that.
Yes. Thank you, Kirk, for that generous introduction. You're too kind. Good morning, everyone. I have to start by expressing my immense gratitude for the invitation to this summit and to offer this keynote lecture. It is truly an honor. Some of you will recognize this photo. It is of the Philadelphia Hope fence. Many of the attendees at the summit in 2023 walked over to the fence and placed our locks with the hopes written on them. And I remember walking away and returning to Boston just so inspired by the summit and by the entire ALK Positive community. The energy that fills each summit is just incredible. It's extraordinary. There's the hope, and there's also your shared purpose and meaning that collectively transcend beyond the walls of the summit, and somehow you all manage to make it better each year. So congratulations. I had this slide initially at the end of my talk, but felt that it was right and felt compelled to also move it towards the front. I want to thank you, the ALK Positive group, for all of the incredible and inspiring work that you do for the patient caregiver community as a group and for the scientific community. You are all leaders in this. I want to thank the ALK Positive Scientific Advisory Board members, some of whom are here in attendance today, and the summit faculty, and all of the other physicians and investigators who have been trailblazers in the field of lung cancer. I'm particularly humbled to stand here right now because much of the key advances that I'm going to review for you in the next hour is a direct result of the work that was led and done by many others sitting in front of me, Dr. Ali Shah, who's mentored me into this field, and many others, Dr. Ross Kamich, Dr. Mark Awad, Christine Lovely, Narjas, Angel, all of you, and many others. So I want to thank you. For today's talk, I chose the title Transcending Boundaries, and this is for several reasons. First and foremost, this is what you do every day, coming together as a group and making the efforts to fundraise for research, to meet with the investigators and the industry partners, to support each other. All of these efforts are driven by a shared desire to transcend today's limitations in therapeutics, prognosis, and the limitations that cancer is imposing on your lives or trying to impose on your lives each day. And I also think that in addition, increasingly, the next effective treatment options will have to be those that are able to transcend the traditional boundaries we've placed between the oncogene subtypes of lung cancer and even between the traditional tumor type boundaries, like between lung cancer and other cancers. We're going to have to look beyond and walk beyond the confines of ALK-positive lung cancer, survey the emerging promising treatment options, and bring those back into ALK-positive lung cancer and make it even more personalized, right? So those are some of the next challenges that we are facing and embracing now. These are just my disclosures. None of these have influenced the talk that I'm about to give, okay? So let's set the stage. What is the current state of treatment for advanced ALK-positive lung cancer? And what ALK inhibitors do we have available right now in the United States that are FDA approved? There are 6, And we classify them into different generations of ALK inhibitors based on multiple factors, like how potently they inhibit ALK, how well they penetrate the brain space and are effective against brain metastasis, and whether they're able to overcome some of the new mutations in the ALK gene that cause cancer relapse on the earlier generation drugs. And so as you can see in this diagram, there are 3 generations of ALK inhibitors that have FDA approvals right now, classified as shown. Since the initial development of ALK-targeted therapies, there's been an incredible evolution of the treatment paradigm. And so many years ago, before I was an oncologist actually, we used to start out with crizotinib, the first generation ALK inhibitor, as the initial therapy for patients with ALK-positive lung cancer. But then when the second generation ALK inhibitors like alectinib and brigatinib came along and they showed effectiveness, they were compared directly against crizotinib and showed superiority. So they supplanted crizotinib as the preferred initial therapy. And then lorlatinib, the third generation ALK inhibitor, became available. It was also compared against crizotinib. Lorlatinib was significantly superior and became a first-line option. I think it's fair to say that for several of the faculty members here today, our current preferred approved ALK inhibitor to use as the first ALK inhibitor if someone's newly diagnosed with ALK-positive lung cancer is lorlatinib. And there are several reasons why. I'm not going to spend too much time on this topic because it has been covered at prior ALK talks and ALK summits, but because more than half of you actually are attending your first summit today, I will provide a high-level overview, okay? So first, the systemic efficacy, the level of effectiveness of lorlatinib, is the most compelling that we've seen for any approved ALK inhibitor thus far. Similarly, secondly, the level of effectiveness in the brain against brain metastasis is the most compelling that we've seen for any approved ALK inhibitor thus far. Third, there are certain downsides to trying to reserve lorlatinib as a salvage option to use later line, as opposed to using it upfront. And then finally, there are some distinct side effects to lorlatinib that we have to be aware of and watch out for. But with appropriate monitoring and dose modifications and supportive medications as needed, most patients are able to derive good benefit from the drug. So in terms of systemic efficacy, if we consider progression-free survival or median PFS, PFS is the length of time that patients are living with cancer before cancer is getting worse, okay? So if we look at that median PFS for second-generation ALK inhibitors like alectinib and brigatinib in trials, that number ranged around 2 to 3 years in different clinical trials. And then for lorlatinib in the CROWN trial, which looked at lorlatinib in the first-line setting, the median PFS has not been reached after 5 years of follow-up, meaning that it's going to be longer than 5 years. I think the improvements that we're seeing in efficacy with these higher generation ALK inhibitors really demonstrate very well how we can push the boundaries with effective drug development in precision medicine. The PFS with lorlatinib is the longest PFS we've seen with any approved ALK inhibitor to date. And in fact, as Dr. Ben Solomon highlighted at a presentation, it is the longest PFS that we've seen with any targeted therapy across all of lung cancer. And so the work that was led by many of the faculty members here today has really led the field of precision oncology in terms of what it's able to achieve with good drug development. In terms of CNS efficacy, the natural history of ALK-positive lung cancer is that without effective therapies, brain metastases are common. Fortunately, we have several higher generation ALK inhibitors that are able to penetrate that blood-brain barrier and effectively treat brain metastasis. However, there are some differences in the level of that effectiveness. Even with second-generation TKIs like alectinib and brigatinib, which are quite effective in the brain, relapses in the brain are not rare events. We experience them actually quite often in the clinic. How about with lorlatinib? These are what we call time to intracranial progression curves on therapy from the CROWN trial that looked at patients treated with lorlatinib as first therapy, shown with the blue curves, and patients treated with crizotinib, shown with the red curves. So what it's showing is x-axis is time, And you're looking at each time point, what percentage of patients who received treatment are remaining free of progression in the central nervous system. On the left-hand side are individuals that had some brain metastasis at the time of enrollment in the trial, at the start of treatment. And then on the right-hand side are looking at individuals who didn't have any brain metastasis at the time of starting therapy. And what you can appreciate is that many patients who were treated with lorlatinib as their first therapy were able to remain free of intracranial progression after as long as 5 years of follow-up. Now, across lung cancer, not just in ALK-positive lung cancer, as higher generation effective targeted therapies have become developed, one of the common questions that have been asked over and over again, time and time again, is should we reserve those higher generation pills in our back pocket as a salvage option, or should we move them towards first-line setting? And time and again, the answer has been, let's move that higher generation pill to the frontline setting. One of the reasons is that as much as we wish this weren't the case, not every individual who has cancer progressing on the first treatment is able to get second-line treatment. So these are pie charts derived from data from the ALEX and ALTA-1L trials, which are the trials that evaluated alectinib and brigatinib as first-line treatment. And surprisingly, about 40% of people did not receive another treatment after that first ALK inhibitor. We can spend a lot of time exploring why that might be. We're not going to do that right now during the talk, but that is a sobering result. In addition, for any given targeted therapy, the level of effectiveness when it's used as a later line option versus as a first option dramatically wanes. That's true for ALK inhibitors as well. So for these reasons and others, we do prefer to try and use the best treatment that we have up front so that as many patients as possible can derive that benefit. Now, I've said a lot of things about lorlatinib, but this is not to say if somebody's been doing really well on earlier generation pills like alectinib or even crizotinib for many years, we're not suddenly recommending a switch to lorlatinib, because there we have the benefit of knowing that your specific cancer is quite responsive to that drug. I wanted to make this talk as practical as possible for you. And so here and there, I've sprinkled in some of the questions that I'm getting asked in the clinic by patients. One of them is, Dr. Lin, I saw ensartinib was just FDA approved for metastatic ALK-positive lung cancer a few months ago. Does this mean that this is the newest ALK inhibitor that should be preferred now? The answer is no. So ensartinib is what we would classify as another second-generation ALK inhibitor. And the FDA approval was based on a phase 3 trial called EXALT-3, where patients who had not received a prior ALK inhibitor enrolled and were randomized to receive either ensartinib or crizotinib as the control intervention. And ensartinib was a better pill than crizotinib. This was an anticipated result. And the level of effectiveness that was seen with ensartinib was quite in line with what we had learned from the other second-generation ALK inhibitors. So there was no clear evidence that it should be better than other ALK inhibitors like alectinib or brigatinib, which are other second-generation ALK inhibitors. And there's also been no evidence to suggest that ensartinib should supersede lorlatinib in terms of the level of efficacy in the body or brain. And so for us faculty members, I think it's fair to say that when the FDA approval occurred, it didn't really change our clinical practice. Another question that I'm asked is, what about NVL-655? I'm hearing a lot about this drug recently from some of my friends in the ALK positive group. Can you tell me more? NVL-655 is also now called neladalkib. It is what we would call a fourth generation ALK inhibitor, and it was developed to try and surmount some of the ongoing challenges in ALK-positive lung cancer. As an example, despite the effectiveness of the existing higher generation ALK inhibitors, there can be undesirable side effects that make one or some of them prohibitive for some individuals. For example, mood or cognitive issues may be in some ways debilitating for some of patients. There can be weight gain that can be pretty significant for some patients, or perhaps painful neuropathy or arthritic pains that are bothersome. As I mentioned, there can be cancer progression in the brain despite the effectiveness of these pills. And especially after lorlatinib right now, there's a desert of options that offer effective brain penetration. And so we really need better options there. And then, of course, there's the issue of drug resistance, which I'm sure many of you have heard about. There can be cancer progression on a given course of therapy, an ALK inhibitor, because of new mutation or change in the ALK gene on top of that ALK rearrangement that your cancer already had. In fact, sometimes, especially after a treatment like lorlatinib, if it was used after alectinib, brigatinib, and others, there can be what we call compound ALK mutations, where there are 2 or more ALK mutations occurring together that make the cancer particularly refractory to the existing agents. And so neladalkib was designed to have a wide range of activity against both single and compound ALK mutations, including those that are lorlatinib refractory. It was developed to penetrate that blood-brain barrier and to be active against brain metastasis, and to be selective against ALK with the goal of hopefully having a cleaner side effect profile. What have we seen? We presented the initial preliminary efficacy and safety data for neladalkib from the phase 1 portion of the ALKOV-1 trial 2 years ago, and then the data were updated last year at the ESMO Congress. Vast majority of patients that have enrolled in this trial had been heavily pretreated, had received multiple ALK inhibitors, including lorlatinib. What you're seeing there is called a waterfall plot. Each of the vertical bars represents the change in size of representative tumors for a given patient who generously participated in the trial. And so a bar going down means that there was a shrinkage in the size of those tumors for a patient, and then a bar going up means that unfortunately the tumors grew for that patient. And what you will recognize is that for most of the patients there was some degree of tumor shrinkage, and for 38% of patients there was actually a significant change in tumor size in the better direction. This was exciting because to date, especially after lorlatinib, there are currently no FDA-approved targeted therapies, right, for ALK-positive lung cancer. And then neladalkib has also shown activity against brain metastasis, including activity observed in some patients who've received prior lorlatinib with still measurable brain metastasis. There's been some responses noted. Again, very encouraging because right now there's a dearth of options that are brain active after lorlatinib treatment. Based on these encouraging results that we've seen from the phase 1 and phase 2 trial of neladalkib, there is now a phase 3 trial, large trial, that will evaluate neladalkib as first treatment given to patients with advanced ALK-positive lung cancer. And here, patients will be randomized to receive neladalkib or alectinib, with progression-free survival being the primary measure of effectiveness. I'm going to come back to the discussion of initial treatment of ALK-positive lung cancer later in the talk to come back full circle, but I wanted to make sure to reserve quite a bit of time to discuss the topic that's actually asked more often in the clinic at a practical level, which is what options do we have after the ALK inhibitors? Over the years, we've learned that in patients treated with targeted therapies generally across lung cancer, if we're able to learn the exact mechanisms biologically why cancer is escaping a given course of treatment, we call that mechanisms of drug resistance, often, not always, but often it can inform us towards determining which treatment approach may be the most promising to use for a given patient. So when we consider lorlatinib used as the first treatment and look at the mechanisms of resistance to first-line lorlatinib, this is an area where there's still a lot of work in progress. We still need to learn a lot of insights there. We've had early look from the data that were presented from the CROWN trial. This was for us just a small number of patients who received first-line lorlatinib, and these were also only based on blood biopsies, which for certain resistance mechanisms can fall in terms of the degree of sensitivity. So a lot of patients are still doing well on lorlatinib in the CROWN trial, which is good news. With those important caveats, in that limited data set, what's been learned is that none of the samples after lorlatinib was found to have an new ALK mutation. What does that mean? That suggests that the predominant reason for cancer getting worse on lorlatinib given as first treatment is going to be driven by a non-ALK mechanism. We call that off-target mechanism. In fact, we're seeing that as higher generation ALK inhibitors are being used more widely, the prevalence of those off-target, non-ALK-driven mechanisms of drug resistance is increasing. This is work that was led by Dr. Sara Waliani, who's a wonderful colleague and a very devoted researcher at Massachusetts General Hospital. And she carefully looked at the frequencies of ALK-driven and non-ALK-driven resistance in patients who received higher generation ALK inhibitors. In particular, she compared the landscape in people that are receiving higher generation ALK inhibitors upfront as first-line therapy. So that's consistent with our current clinical practice, right? Versus in patients who had started out with crizotinib and then received higher generation ALK inhibitors. The pie charts are showing that whether you're looking at tissue biopsies or blood biopsies, the frequency of ALK-driven resistance is actually significantly lower if you're starting out with higher generation ALK inhibitors upfront. Meaning that, again, off-target mechanisms of resistance are going to be becoming increasingly frequent and increasingly important to try and address going forward. Why are we even talking about this? Why does it matter? Because as you might imagine, if a cancer is growing because it's found a new mutation in the ALK gene, then if you have access to another ALK inhibitor that's able to target that mutation, that could be a really good treatment strategy to use. On the other hand, if cancer is growing because of a non-ALK-driven mechanism, then simply making that switch to a different ALK inhibitor is probably not going to be the best way to go. And you need to look for alternative strategies like chemotherapy or non-ALK-driven, non-ALK-targeted treatment approaches. To that end, some patients have asked me, oh, I heard my friend is getting treated with an ALK inhibitor with a MET inhibitor combined. Is that an option for me down the line? And the answer is perhaps. And that is in the case that we know the cancer is growing or has become resistant to ALK inhibitors because of MET amplification or increase in the numbers of copies of the MET gene. Our group and several others have reported MET amplification as a recurring mechanism of resistance to higher generation ALK inhibitors. It is not rare, and it does guide our treatment discussions. The schema on the left-hand side shows the treatment history of a patient at Mass General with ALK-positive lung cancer. Alice knows this patient. This patient received multiple ALK inhibitors, including lorlatinib. And at the time of cancer growth on lorlatinib, rebiopsies were performed, and multiple tissue sites were found to have acquired MET amplification. Interestingly, one of the biopsied sites also had, on top of MET amplification, a new gene rearrangement involving the MET gene. So this patient went on to be treated with lorlatinib plus crizotinib. Some of you may be asking, why crizotinib? Why are you adding another ALK inhibitor? In this case, crizotinib is being used as a MET inhibitor. It's a pill that blocks not just the ALK protein, but MET protein and another protein called ROS1. And on that combination of lorlatinib plus crizotinib, the tumor and the fluid in the lung shrank nicely, a lymph node shrank in size. So that's kind of the example of a response we can see with this targeted combination approach. Dr. Ibi Dagogojag at Mass General has done a lot of studies trying to understand how often does this phenomenon occur and what is the most effective way of overcoming that resistance. And she and her group was able to report that MET amplification is seen anywhere from about 12 to 25% of patients after higher generation ALK inhibitors. And in these patients, when you inhibit ALK and MET together, over 40% of patients are able to have a significant shrinkage in tumor size. This is very concordant with what we've seen in another oncogene subtype of lung cancer called EGFR mutated lung cancer. We think of EGFR mutated lung cancer. I'm going to come back to EGFR lung cancer a little bit later in the talk, so I want to tell you, it's thought of as in many ways biologically similar to ALK positive lung cancer. We see MET amplification in people with EGFR mutated lung cancer after they have cancer treated with EGFR targeted therapies, EGFR inhibitor pills. And in those patients too, this strategy of combining EGFR inhibitors with MET inhibitors has been tried, and the level of effectiveness is very much in line with what we've seen in ALK-positive lung cancer. In fact, we've seen MET amplification in other subtypes too, like ROS1 lung cancer. and red lung cancer. So this is an example of that concept that transcends across different subtypes of lung cancer in patients. So should we get a rebiopsy if cancer is progressing? The answer from my viewpoint is yes, at most time points, if it is feasible. And there's actually a lot to discuss here, so we're going to come back to this topic during the Ask the Expert session and key opinion leader panel as well. Briefly, rebiopsies can serve multiple purposes. So again, we can do both tissue biopsies and blood biopsies. If tissue biopsy is taken of a growing site of cancer, first of all, it can allow for histopathologic examination. What does that mean? It can allow us to look at whether your cancer, most often ALK positive lung cancer, has what's called adenocarcinoma morphology or subtype. Sometimes after ALK inhibitor treatment, that can transform or change to another subtype like squamous cell lung cancer or small cell lung cancer that is relevant in how we think about next treatment approaches. With either blood biopsy or tissue biopsy, we can do what's called the next generation sequencing or NGS. Many of you are familiar with this. NGS allows us to look for new alterations in genes like new ALK mutations or MET amplification. With tissue biopsies, we can additionally perform immunohistochemistry or IHC studies. IHC studies are looking at the level of expression of a specific protein of interest in the tumor cells. So an example picture here is showing the result of an IHC against protein MET. So it's looking at the level of expression of a MET protein in a patient with ALK positive lung cancer. And the brown color is showing that there was strong expression of MET in this patient's sample. Why am I talking about IHC studies and protein expression here? The reason is as follows. So until recently, in fact, until just last year, when we were talking about actionable markers in lung cancer, almost always we were talking about gene biomarkers, like EGFR mutation, like ALK rearrangement. Those are what we call actionable genomic alterations or biomarkers. Those are shown in green color. Over just the last few months, we now have available actionable protein biomarkers. So these are protein markers, level of expression of a protein where there are matched FDA-approved therapies available. So there are two protein biomarkers right now with FDA-approved therapies. There can be HER2 overexpression or ERBB2 overexpression, where if there's strong level of HER2 overexpression, a drug called trastuzumab deruxtecan is FDA-approved. There can be MET overexpression, where if there's a strong level of MET overexpression, telisotuzumab vedotin, or Telis-O-V, is FDA-approved. Mind you, these are distinct from gene mutations. So MET overexpression is distinct from a MET mutation or even MET amplification that we talked about before, although in some cases there can be overlap. And then HER2 overexpression is different from HER2 mutation that the NGS reports will sometimes read out. I wanted to make sure to mention this to you today and share the evidence behind these approvals because these are relevant to you. HER2 overexpression and MET overexpression is not mutually exclusive to ALK rearrangement. Okay? ALK positive lung cancers can have, for example, strong MET overexpression. And when those biomarkers are present in the cancer as detected by IHC studies, that does mean that these drugs and perhaps other investigational therapies on trials become added to your potential treatment arsenal in the future. So these are important to keep in mind. These two drugs belong to a class of drugs called antibody-drug conjugates, or ADCs. An overly simplified definition of ADCs is that these are kind of like smarter chemos, where chemos are trying to be more selectively delivered to cancer cells. They all have three main components structurally. So there's the antibody component in the antibody-drug conjugates. The antibody component is what delivers the drug to the cancer cells. The antibody recognizes the antigen or the protein expressed on cancer cells. There's the drug component in antibody-drug conjugates. That's the cytotoxic payload, or often chemotherapy, that's killing the cancer cells. And then there's the conjugate component, which is the linker. It's a bridge between the antibody and the drug. So what happens is that the antibody component of the ADC recognizes the antigen on cancer cells, the protein on cancer cells. It brings ADC to the cancer cells. It can get internalized. The linker releases the chemo, the cytotoxic drug, and that leads to the desired tumor activity. That's the whole concept behind ADCs. Trastuzumab deruxtecan is an ADC that's targeting HER2. And for lung cancers with strong HER2 overexpression, this agent became FDA approved 3 months ago. The approval was based on several trials. One of these trials was called DESTINY-Lung01. It was a phase 2 trial that enrolled patients with both HER2 mutated and HER2 overexpressing lung cancer. And there was an activity in patients with HER2 overexpressing lung cancer, as shown by the waterfall plot here. There was another trial called DESTINY-Lung03, which also looked at the activity of this drug, trastuzumab deruxtecan, in patients with HER2 overexpressing cancers. And in those patients that had strong level of HER2 overexpression with lung cancer, the response rate was 56%, and the median duration of response exceeded a year. I mentioned MET overexpression as another protein biomarker. Telisotuzumab vedotin, or Teliso-V, is the MET-directed ADC that was FDA approved a couple months ago. So this was actually based on a phase 2 trial called Luminosity, which was led by Dr. Kamich here, so he should be talking about this, but I'll try to do it justice. In patients that had strong MET overexpression, about a third of patients were able to experience significant tumor shrinkage with Teliso-V, and there was a good, promising duration of response. So this is why Teliso-V is now approved. And then there's a newer MET ADC that some of you may have heard about called telisotuzumab adesotecan, or TMAP-A. This is also a MET ADC. It has the same antibody, telisotuzumab, that recognizes MET, but it's linked to a distinct cytotoxic drug. There were preliminary results for a trial looking at TMAP-A in patients with EGFR-mutated lung cancer after EGFR-targeted therapies. These were presented at the ASCO meeting a few months ago, again by Dr. Kamich. And as you can see in the waterfall plot, there was really encouraging activity that was noted. In fact, the level of effectiveness you could even guess was a little higher. Response rate of over 60% is quite exciting to see, and median PFS of 10.9 months. And what was particularly noteworthy with this agent is that activity seemed to be observed across a broader level of MET overexpression. The reason we care about that is because that suggests that perhaps this agent could potentially benefit a larger population of patients. And so the last ADC I will mention is datopotamab deruxtecan. This is a different ADC that targets a protein called TROP2, which is overexpressed in many lung cancers and other cancer types. This agent received FDA approval just a few weeks ago for EGFR-mutated lung cancer. So in patients who had received prior EGFR inhibitors and chemotherapy, about over 40% of patients had significant tumor shrinkage. And then this agent also demonstrated activity in patients with ALK positive lung cancer. I know the numbers are probably harder for you to appreciate, but I did want to point out that this is an agent that has been evaluated and has shown activity in patients with ALK positive lung cancer. Some investigators have pointed out that the level of effectiveness seemed lower in ALK positive lung cancer than EGFR lung cancer. However, there are important caveats there, including that the number of patients enrolled in these cohorts were quite small, and the patients were distinct. Many of the patients who enrolled in this trial with ALK positive lung cancer had received many, many prior lines of therapy, which can affect the level of effectiveness of any given drug. So I'm personally looking forward to seeing more results for not only TROP2 ADCs and other newer MET ADCs, but ADCs as a class in general. The reason I spent several minutes on this is because I want you all to remember that now standard of care testing on your cancer biopsies is not just NGS testing. It includes IHC testing for these proteins. Because these are new treatment advances, in many cases, this testing may not have been performed on your original tumor biopsies. So you can make sure to discuss these with your oncologist. MET and HER2 IHC is now standard of care. Our group at Mass General and other groups have looked at the level of expression of these ADC targets in oncogene-addicted lung cancers, including ALK-positive lung cancer. And if you look at the far left-hand side curve there, under ALK, what it shows is that a good number of patients with ALK-positive lung cancer will have strong overexpression of these ADC targets, including MET. And so again, these are possible in your cancers as well. The last protein of interest that I'm going to discuss a little bit today is MTAP. This is relevant because there is an emerging class of therapeutics that are showing promise for cancers with MTAP loss or MTAP deletion. I think Dr. Shaw talked about this at a prior ALK talk, so I'm not going to go into it in too much detail. MTAP is a gene that's located very close in physical proximity to another gene like CDKN2A. Some of you may have seen this gene name in your NGS report. And that's because CDKN2A, CDKN2B loss is very frequent actually in lung cancers. And MTAP is often lost, deleted together with that gene CDKN2A, CDKN2B. In fact, across lung cancers, the frequency of MTAP loss is about 10 to 15%. In these cancers that have MTAP loss, not just lung cancer actually, in every cancer type, if there's MTAP loss, that means there can be an associated unique therapeutic vulnerability in the cancers where they become susceptible to treatment with agents that impinge on pathways that are affected by MTAP loss. One of the class of drugs that has shown promising result in this class of cancers is MTA-cooperative PRMT5 inhibitors. It's a mouthful. But there are several drugs that belong in that category where we're seeing exciting results. I've just shown one of them here from Bristol Myers Squibb. These were results presented by Dr. Catherine Arbour from Memorial Sloan Kettering at the ASCO meeting. And here, there was, as seen in the waterfall plot, patients with different cancer types with MTAP loss who derived benefit from the drug. Specifically in patients with lung cancer with MTAP loss, about a third of patients experienced significant tumor shrinkage. So because of this, at our center and several others that are led by the investigators here, we have started to do MTAP IHC testing as well to look at the level of expression of MTAP protein in order to identify those individuals who may benefit from being considered for the ongoing clinical trials. MTAP loss can also be detected by NGS that may have been done in your case. It's just the level of sensitivity may be a little lower, depending on which NGS assay was used. We're going to switch gears to another topic. A question that I get asked just as often these days as several years ago is, can I try immunotherapy as a next treatment? I've seen many patients with lung cancer getting immunotherapy and doing well. Conversely, we should avoid immune checkpoint inhibitors, correct? The answer is typically yes, that's correct. Generally, we know that the available anti-PD-1, PD-L1 immune checkpoint inhibitors like pembrolizumab, nivolumab, they do not tend to provide significant benefit for patients with ALK positive lung cancer and other oncogene addicted lung cancers like EGFR mutated lung cancer. But rest assured, there is a large effort throughout the globe by investigators like those that are here today who are trying really hard to figure out how we can deliver and leverage the benefits of immunotherapeutic approaches for patients with ALK positive lung cancer. Some of you may have heard about a drug called ivonescimab. This is a novel drug. It's a bispecific antibody that binds to two proteins, the PD-1 immune checkpoint protein and the VEGF protein, vascular endothelial growth factor. This is an angiogenesis protein that promotes new vessel formation and promotes tumor growth and metastasis. Ivonescimab has been investigated in several large and small clinical trials for patients with advanced lung cancer, including EGFR mutated lung cancer, which again, biologically, in many ways can behave similarly to ALK positive lung cancer. And patients with EGFR mutated lung cancer also don't tend to benefit from drugs like pembrolizumab and nivolumab. One of the trials was called Harmony-A. This trial was a big phase 3 trial that enrolled patients with advanced EGFR mutated lung cancer who had received prior EGFR TKI therapies and experienced disease progression. The patients were randomized to two different treatment arms. The control arm was the standard of care treatment at the time, chemotherapy by itself. Now for ALK positive lung cancer too, after ALK inhibitors, chemotherapy is considered standard of care, right? So the control arm was the chemotherapy, and then the study arm was ivonescimab, this new drug added to chemotherapy. And the trial report of the result was that there was a significant lift in PFS, or progression-free survival, when ivonescimab was added to chemotherapy. If you look at the 6-month mark, there was a 20% jump in patients remaining free of progression. And so this was an exciting result for many lung cancer specialists at the time that it was presented, because again, patients with EGFR mutated lung cancer typically had not responded to anti-PD-1 checkpoint inhibitors that were available. There's preclinical evidence as well in ALK-positive lung cancer that support that VEGF-VEGFR pathway inhibition can be a relevant treatment strategy. ALK signaling pathways and VEGF-VEGFR signaling pathways can intersect in ALK-positive lung cancer. And after ALK inhibitor treatment, there can be induction of expression of several components in that pathway. So I don't have time to go into all of the details today, but based on all of these evidence together, we have designed a clinical trial to further investigate ivonescimab, this time for patients with ALK-positive lung cancer, as well as other oncogene subtypes of lung cancer. The trial is going to enroll patients that have received targeted therapies like ALK inhibitors, and some of the patients will receive just ivonescimab if they've also received chemotherapy before. If they have not received chemotherapy before, they will receive ivonescimab together with chemotherapy. And the reason ivonescimab is particularly appealing is that the half-life of this agent is short, which means that it may hopefully mitigate some of the toxicities we can see with some targeted agents when they're resumed after immunotherapeutic agents. So this trial has been fully committed to by Summit Therapeutics, which is the company that's developing this drug, and we're in the stage of developing robust correlative analysis in order to hopefully allow us to identify those patients that are most likely to benefit from these approaches. For the last few minutes, as promised, I'm going to come back full circle and return to the topic of initial treatment for advanced ALK-positive lung cancer. One of the questions that many of us are asking a lot these days is, how can we do better? How can we allow more patients, as many patients as possible, to get as long as possible on any ALK inhibitor therapy? I had shared with you some of the PFS data, the progression-free survival data for the existing ALK inhibitor therapies, and about how lorlatinib results definitely stood out. The truth of the matter is that even with a really effective drug like lorlatinib, there are unfortunately some individuals who are experiencing cancer progression early on. So in this PFS curve, in the gray box are people that are experiencing cancer progression within 2 years of therapy, and there are even people that have cancer progress within 1 year. So the question is, who are these patients? Why is this happening? How could we identify these patients before the progression happens to see what the risk is? And could we potentially circumvent that progression event somehow using another intervention? Studies have shown that even at the time of maximal response to effective drugs like ALK inhibitors, there can be tumor persister cells that persist, simmer along, form the nidus of residual disease. So residual disease may be that lung nodule that you're still seeing on scans when you're responding well to therapy. It could be in the form of ctDNA that is still positive when you're responding to a drug. That residual disease and persister cells can go on to then acquire mechanisms of resistance that result in frank cancer relapse that patients experience. Now, our current treatment approach is we start on ALK inhibitor therapy, and we monitor vigilantly with scans, right? And if there's progression on the scans, then we say it's time to switch. Could we envision a future where that treatment approach is different, where we can identify who's at higher risk of progression earlier versus not? Could we have the right intervention to deliver at the time of maximal response to therapy, at the right time to those patients, so as to prolong disease control and maybe even achieve that cure that we're all going for? That was the basis for the formation of the Breakthrough Cancer BTC Lung Cancer Team Lab Collaborative. There are investigators from 9 institutions who are all committed to advancing outcomes of people living with ALK-positive lung cancer who've come together for this effort. These photos were taken at the inception of that collaborative. They include some of the members, and you'll recognize some faces there. One intervention that's being considered is what we call local consolidation therapy, or LCT. I had to throw in artificial intelligence somewhere in my talk. So this is a definition of LCT given by Google AI that was actually quite good. So I just copied and pasted it here. So LCT is a treatment strategy that focuses on eradicating cancer cells at specific locations in the body, often after initial systemic therapy. It involves using local therapies like radiation, surgery, ablation, with the goal of targeting the primary tumor site and or any known metastatic sites. The goal is to eliminate residual cancer cells and potentially improve outcomes. So this concept, again, of persister cells, residual disease, and interventions like local consolidation therapy are concepts that translate across oncogene subsets of lung cancer. In fact, they could even be applicable to any anti-cancer therapy, including immunotherapy and chemotherapy. For example, in EGFR mutated lung cancer, LCT has been tested several times. There was a randomized phase 2 trial that enrolled patients doing well on EGFR inhibitor therapy that had been initiated within 4 months. And then they tested whether adding radiation as LCT improves outcomes. And in this trial, relatively limited number of patients, there was a good lift in PFS as well as overall survival. In ALK positive lung cancer, Dr. Yasser Elamin and MD Anderson has led the Bright Star trial, looking at the role of LCT here. This one was for patients treated with brigatinib as their first ALK inhibitor. He presented the initial preliminary results at the World Conference of Lung Cancer in 2023. And here, most of the patients that enrolled in the trial were able to get the intended LCT, mostly radiation, speaking to the feasibility of this approach in ALK positive lung cancer. The PFS numbers that were presented looked promising, although we are waiting to see longer follow-up data, and also asking what this might look like with even higher generation ALK pills like lorlatinib. Vaccine approach. Many of you have asked about vaccines. So vaccines are a burgeoning field of therapeutics. If I can rewind one slide, perhaps somebody can help. Thank you. So vaccines are a burgeoning class of therapeutics that are being tested not just in ALK positive lung cancer, not just in lung cancers, but across cancer types. There can be individualized, personalized neoantigen vaccines that are tailored to the neoantigens, proteins that we know are in your specific cancer. There can also be vaccines designed against tumor-specific antigens that are shared across a cohort of patients, for example, ALK. So as an example of individualized neoantigen vaccine, there was this vaccine called V940 that has been tested in patients that have high-risk resected melanoma. And here, adding the vaccine to pembrolizumab immunotherapy, which was the standard of care, resulted in a significant increase in recurrence-free survival of melanoma, as well as distant metastasis-free survival. So this is an approach that's being investigated in lung cancer as well. What about ALK vaccine? ALK is an appealing vaccination target, particularly so because ALK is so heavily restricted in terms of its expression to tumor tissue and not expressed in healthy adult tissue. And that's important when you think about potential toxicities, right? And we also know that ALK is immunogenic. And so some of you are familiar with a trial that's been open at Johns Hopkins, led by Dr. Vincent Lam. That was a pilot trial, small trial, looking at ALK vaccine in patients doing well on ALK inhibitor therapy. It was designed as a feasibility trial, and it enrolled really quickly with a long wait list of patients, attesting to the level of interest and enthusiasm in this community for vaccine trials. Dr. Roberto Chiarelli at Children's Hospital and Dr. Mark Awad from Sloan Kettering, who's here today, have led amazing amount of work trying to bring new ALK vaccine trials, more trials for patients with ALK positive lung cancer. So we're looking forward to that. Ultimately, we're going to have to figure out molecularly, clinically, who are the patients who are at higher risk of progression, so that we can define the right population of patients where we can tailor therapies further to improve outcomes. And that is an ongoing area of focus for the BTC Lung Team Lab investigators as well as others. So with that, I have my parting summary thoughts here. ALK inhibitor development has exemplified advances in targeted therapy with features that transcend prior limitations with targeted therapies. Emerging therapeutic options for ALK positive lung cancer often transcend the traditional oncogene subtype boundaries and tumor type boundaries. And finally, efforts to understand persister cell biology and address residual disease offer hope for the next major advance in therapy and prognosis. I want to thank you again for being such incredible people, and I want to thank the faculty members. I learn from you every day. Thank you.